So welcome everybody. This is the National Informal Discussion Group for Primary Care and Personalised Cancer Care. My name's Sandra Dyer. I'm primary care nurse and primary care nursing clinical advisor for Wessex Cancer Alliance. So firstly, welcome to anybody who's new on the call today. Just a bit of background about the group. It's been running now for probably about 3 years. We aim for quite an informal group, and we definitely want interaction and discussion, but in a sort of structured way. So we'll go through that in a second. But essentially, this group is for anybody with an interest in personalised cancer care in primary care. So please do tell colleagues about us and get people to sign up. We meet about every 3 months, and you should have calendar invites for the rest of the year. Let me know if you don't, because something will have gone wrong. Yeah, it's an informal meeting. We'll get on to participation in a second. We are recording it because there's people that can't always attend all sessions, so good to record. If you don't want to be on camera, just keep your cameras off. And if you're tweeting, there's the Wessex Cancer Alliance hashtag at the bottom there. So if you can keep yourself on mute unless you're talking, particularly when presenters are presenting, just to avoid any disruption. Generally better to keep your cameras off when presenters are on, just makes for a better quality session for everybody. You can post your questions in the chat, and there's also the opportunity after each speaker to verbally ask questions as well, and that's where we're kind of going for the interaction. But if something comes to you as we're going through, please just put it in the chat, and we'll pick it up at the end of the each presentation. Also, just to say, both presenters have agreed to share their slides, so I'll share them after the session. So don't think about needing to take copious notes. And then the recording will be edited, and I'll send you a link once it's available. So I'm going to pass on to our first speaker, who is Heather Burgell, who is a GP and GP advisor for Manchester Cancer Alliance in their personalised care team. So over to you, Heather.
Fantastic, thank you. I'll just skip forward to my first slide then. Yeah, as Sandra said, I'm Heather. I'm a GP in Tameside in Greater Manchester, and for the last year and a half or so, I've been working with the Greater Manchester Cancer Alliance personalised care team. Primarily for the first year or so, we were focused on cancer care reviews in primary care, and I contributed to a project, a quality improvement project on cancer care reviews. So I'm just going to give a bit of an overview of that project, kind of what it entailed, why we did it, and some of the feedback that we got from that project as well. So hopefully this will all work. So I think we probably all know what cancer care reviews are. The aim of a cancer care review is to equip patients to self-manage their following their cancer diagnosis and know where to turn to for help. The cancer care review is meant to be quite holistic rather than quite clinical, and it's an opportunity for patients to discuss their concerns. Predominantly that should be done within the first kind of 12 months following a cancer diagnosis, but many patients feel it's better placed after their discharge from secondary care, or at least the completion of some rounds of treatment, because initially there's lots of appointments for patients to go to, so they find it a little bit overwhelming often initially. It was shown, we did some data gathering across Manchester, and it was shown that actually, above 90% plus of cancer care reviews are being coded as being done. But when you actually ask patients, they were unaware that they'd even had a cancer care review in many cases. And that kind of highlighted to us that there was a massive variation in the quality of the cancer care reviews that were being done, and if they were actually being done at all, whether it was just a quick question at the end of a normal consultation about something different and then coded as a cancer care review. So the main aim of the project was actually to improve the quality of cancer care reviews for patients across the board, and to upskill members of the primary care team. So it wasn't just GPs being able to do these cancer care reviews, it was also practice nurses, care coordinators, and other people to be able to train people up to do them. You probably
just
aware
going
of
to say
sorry,
that your slides aren't moving on. Let me, yeah, I've moved on to your first one, but just let me know and I can move them on for you.
So I'm on the one that says QOF targets now. It's moved for me. Have we got the right one now?
Yeah, if you just let me
I'll
know, I'll
just say
move them
next
on for
slide.
you.
Yeah.
Yeah,
So
be
we're
easier.
probably all
Thanks.
aware of the QOF targets. Now these actually were income protected last year and now have been completely got rid of, as probably aware. But essentially, the QOF targets did stipulate that patients with a diagnosis of cancer should have an offer of a cancer care review within the first 3 months, or at least a acknowledgement of their cancer diagnosis and offering of support. And then within the first 12 months after a cancer diagnosis, they should have an actual standalone, holistic kind of conversation. So if you could just go on to the next slide, please, Sandra. Now it's not moved for me. I'll move on my own. So in terms of why this is important, so as we're aware, the number of people living with cancer is increasing massively. As you can see from the graph on the right, it actually dropped off a little bit, the number of diagnoses during COVID, but that has now increased again. But importantly, that black line on the second graph shows that the number of deaths has actually stayed quite stable, which means that more and more people are living beyond their cancer diagnosis. And in primary care, we're very well placed to kind of help these patients to live well beyond that diagnosis and potentially with late effects of their cancer treatment. So if we just go on to the next slide, Sandra. So the importance of this personalised care and obviously the cancer care reviews is that many patients following a cancer diagnosis have so many late effects of their cancer treatments, but also psychosocial impacts of that cancer diagnosis. So as you can see, there are some studies from the University of Bristol found that 4 in 5 people with cancer are on average £570 a month worse off because of their cancer diagnosis, and that has like massive implications for patients. Patients have often lost work, they may be anxious and depressed, and they might be feeling quite lonely following, say, the loss of friendships or independence. And therefore, you know, in primary care, they're becoming our patients, this is becoming more of a chronic disease, and we can play a big vital role in helping them live well. Next slide, please. This is just to summarise some of the late effects on that Macmillan picture on the left-hand side. These are some of the kind of physical late effects of cancer and the treatment. So there's often quite a lot of heart disease, breathing difficulties, swallowing problems, dietary issues, but often quite a lot of common concerns that patients raise as well, such things as fatigue, finances, work, mental health, sexual well-being being a big one that was brought up in a lot of our patient focus groups when we were talking about designing the template that we did. So next slide, please. So in Greater Manchester, we run a cancer care coordinator pilot where cancer care coordinators were employed to work within PCNs, their role was to help patients with cancer navigate appointments, understand their diagnosis, understand their treatments, but not to be so clinical really, is actually to support them and help them potentially just to navigate the complex system that sometimes there is when a cancer diagnosis is reached. And actually, they also undertook the cancer care reviews, and it was found the patient feedback from these cancer care reviews was really encouraging. Patients found it was really helpful to have that conversation rather than a consultation. There was time during those conversations to dissect some of the barriers. That was some of the feedback that was given. And actually, in terms of number values, there was actually some evidence that they just reduced the number of GP appointments or patient-generated GP appointments for things such as asking for support, or even such things as physical symptoms, because the cancer care coordinators were able to direct patients to where to get those support that wasn't potentially a GP. So if we go to the next slide. So following off from that really successful project, it became quite clear that there was no real standards of kind of what a cancer care review should entail and what it should look like, and how it should be done well. So we set about designing what we called our cancer care review package. And this was a number of different materials that was sent out to all the primary care providers across Manchester, for them to use as they pleased, basically, as they wished. And this was the package that we designed. So there was the standards, and I'll go through each of these in slightly more detail, which in the standards included kind of a bit of a guide, what should be included in a cancer care review, a protocol to help practices kind of navigate the system, a new diagnosis letter, which practices could modify and change according to what they felt fitted, but essentially was to be sent to patients when they received cancer diagnosis. And then we also designed a new template, and we all use EMIS across Greater Manchester, so it was a new template within EMIS to help people, GPs, practice nurses, to be guided through a cancer care review process and conversation. It was more of a guide than an actual kind of, tick box exercise. These were all kind of put together and then put on our website, as well as being distributed amongst the practices. And then finally, there was culmination of that into a 2-hour educational webinar, which was well attended, and is also free to kind of look back at and learn from, for future learners as well, to try and upskill members of the primary care workforce. So if you just go on to the next slide, I'm just going to kind of go through each of these just in a little bit of detail, but it's all available on the website as well. So the standards, these were developed, all of these materials were developed alongside patient representatives as well as clinicians. The key points of the standards was that the cancer care reviews didn't need to be just done by a GP. They could be done by practice nurses or care coordinators, or any member of the clinical team that felt they had the appropriate training to do so. Patients should have been given an opportunity to prepare, and that could be via the new diagnosis letter, which details about the cancer care reviews. And ideally, it should be a pre-booked appointment, recommended to be 20 minutes. Although I know in my practice, we do 15-minute appointments, and that seemed to be sufficient in many cases. But importantly, it shouldn't have been just a question on the end of a consultation about something different, or on a COPD review, or on the end of a diabetes review. It should be a standalone appointment specifically to talk about a patient's cancer. And people are encouraged to use the templates, although not, again, that's not necessary. People can do it however they please. But that people are encouraged that it's the start of a continuous process rather than just a standalone. A little bit like how practice nurses would follow up COPD patients every year. So if you just go to the next slide, that was the standards. And then just flick through to the protocol, which was the following slide 14. So this is the protocol. It's a little bit busy, but again, it was more just a guide to help practices to navigate the system, because it was a bit confusing kind of what came where. So the blue kind of column in the middle is the process. So cancer diagnosis is received by the practice, and ideally clinicians, whoever did, for example, a 2-week wait referral, might feel that they're well placed to actually just contact that patient and acknowledge the diagnosis first of all. Then the new diagnosis letter sent to a patient, and that has invitation to arrange appointments if they need it, but also some really useful local support information. The cancer care review invites then sent a little bit later, and talking to patients, a lot of them said that 3 to 9 months post diagnosis was kind of the ideal time, but again, that's very patient dependent. And then when the invite's then sent and the cancer care review is then conducted, clinicians are encouraged to look to see if there's an end of treatment summary or a personalised care and support plan, which can help to guide the cancer care review. So if we just go to the next slide, the new diagnosis letter looked a little bit like this. So it was kind of a standard looking letter, but then practices could add in any specific support that was available in their kind of PCN or their local area. This fulfilled the CAN 005 QOF target, which was the offer of a cancer care discussion, and also offering local support availability and things like that. And this was able to be sent to patients. And I know that there's quite a few practices using this or something similar to this when a patient gets a cancer diagnosis as well. So if you just go to the next slide. And then finally, a big part of our project was looking at was creating a new cancer care review template. The Macmillan template is available on all our systems as well, and I know some people prefer still to use that one. But we wanted to give an option for a more freehand template, which helped to prompt questions, but not necessarily stipulate the exact structure, and wasn't so much tick box. It was more of a holistic discussion. Again, we did lots of focus groups, including patients in that, about what was important, and things such as sexual well-being in relationships was brought up at all of those focus groups to be important for patients, and actually that they rarely got asked, but actually if they're given the opportunity, they would have quite happily talked about. So what we came up with a kind of a list of things that could be covered, but no kind of forced entry to absolutely have to to fill any of them in, except for obviously the one that got the quaff box, which was the cancer care review completed tick box. It includes things like care and social prescribing. So actually, a lot of the patients again spoke about how they felt that their carer, so their spouse or their sons, daughters, were kind of not not given the support that they felt that they would have benefited from as well. So actually, the question is asked, actually, are you a carer or do you have carers? And that was quite important, I think, to patients as well. So the left hand side of here just shows the little bits of the kind of this is the major kind of the box, but then there's care and social prescribing, medications, and then follow-up support and signposting. And then if you just go on to the next slide, the final page was the resources page. And this was kind of highlighting some of the really key resources that was available, and kind of little leaflets, for example, for fatigue, pain, things like that, most of which were from Macmillan or Cancer Research. But I find this quite useful to use, because you can click on these, it opens the web page there in front of you. You can copy and paste the web address and then text it to the patient on a texting system, so they can go home and open it on their phone, rather than having to print it off and things. So that's quite useful. So I encourage people, even if they're not using the template itself, they can just use it for the resources page, which people find helpful. So if we go to the next slide, all the materials were then put onto our website, which is the Greater Manchester Cancer Alliance website. It's under the personalised care tab, and then there's a cancer care reviews page, and they're all available there, including a little bit of educational material as well. And then finally, if we just go on to the next slide as well, it all culminated in November in a 2-hour webinar. We had about 85 people attend, and there was a range of different people, clinicians, and administrative staff as well, that attended the webinar. We had people talking about the psychosocial impact of cancer, the physical impact of cancer, and then there was also a section on actually undertaking the cancer care review and how it might kind of be undertaken. So it's free. It's on the Academy website, and it's a free. You can just sign up for that for free as well. So that's for anyone to access. So if you just go on to the next slide, we sent out pre-questionnaires, and we're going to send out a post-questionnaire as well, kind of 4 months down the line or 5 months down the line now, to see whether it's changed people's practice. But this is just a bit of a breakdown of some of the feedback that we got. So we had 66 people complete the feedback on the day. And as I said, there's some more that has come in on demand as well. And 38% of people before the review, before the webinar, said that they felt confident supporting people with cancer, and that increased to 87%. So that was a really, really positive outcome. And again, the number of people who felt confident to actually deliver a high quality cancer care review increased from 52 to 97% following the webinar. So there was some kind of really good feedback. And if you could just go on to the next slide, there was also some kind of written feedback as well. And just to highlight the kind of the pink, the light pink speech bubble here, which says, "I've discussed this today at our team meeting. I always felt that it was better placed within the nursing role. now I had the knowledge and training to justify why I feel this way, and we have agreed to change the practice based on this. So that was exactly the outcome that we wanted, really. People that felt that they were really kind of encouraged to undertake the cancer care reviews themselves and know what to do, essentially. Our practice, it's our practice nurse who does the majority of our cancer care reviews, and she actually follows patients up, quite often. She'll leave it to them to make a follow up. They might, touch base every 3 months or so, but she finds it really rewarding, a very rewarding part of her job to follow these patients. She speaks on the webinar, and she had a personal journey with cancer herself, and she feels that she's able to kind of identify with a lot of the worries that patients have. She often doesn't share her experience with the patients, but she vocalizes that on the webinar, that she uses that really to help her do the reviews. And it was just really encouraging. So hopefully we've had some impact. It was difficult to reach everyone in Manchester, but it's just kind of little ripples, I think, that you start the conversation. And hopefully, although the QOF targets have been kind of taken away, it will be kind of business as usual with the cancer care reviews, and actually these things will continue, and the support that patients get will continue on. So that's it, really. That's my email address. If you've got any questions or any queries, I'm happy to answer them. Or if you've got any questions now.
Thanks, Heather. Very well summarised, a big piece of work in 15, 20 minutes. So well done for that. So I can see there's a couple of people with hands up. So let's see who they are. So Barna, I think you're first.
Thank you. Thank you very much, Heather. It was a great presentation. I'm a GP and one of the clinical lead for our Cancer Alliance. It's not a question, it's a comment about the QOF retiring. And I think you can hear me what I'm trying to say. Although the QOF is going, but the continuity of care is still to stay with primary care. So we're not going to have that dedicated time just to have that discussion with the patient. My question is how I have a feeling in PCN, the cancer care coordinator gradually going to disappear, become a care coordinator. So the cancer part of it is going to go. It's very important to have for our patient. I can see in our PCN, patient really appreciating having somebody to go to for any support, anything, how we can keep the momentum going. Because with the treatment with the survivorship, these people coming more and more to primary care, and if we lose that, it's going to be such a shame. Any insight would be helpful. Thank you.
Yeah, no, I think that is a concern, isn't it? And I think we hope that it will be business as usual, but I can imagine that there will be some practices that never particularly did the cancer care reviews when they were QOF targets, and now really they don't continue. I think the more that it's not just a GP job, I think that encourages lots of different clinicians to be able to do them. I think that helps maybe to encourage that kind of continuous process. I think care coordinators are well placed to kind of navigate and help cancer patients through their journey. And I also think practice nurses, maybe during their the chronic diseases reviews, for example, a little bit like that, cancer conversations will happen. It might not take on the same structure as a cancer care review per se, but it's about, I suppose, like you say, knowing who to go to for help. We are now working on a project for the end of treatment summaries, and again, there's lots of concern that we're not seeing them regularly in primary care, but we're trying to raise awareness about them and the importance of knowing about late effects, and about the kind of the ongoing care of patients. And I think, just for example, they're really useful, the end of treatment summaries, because they have key contact details in them, and I think that's encouraging as well, to be able to know where to turn to for help. I don't have any particular answers, and I just hope that generally, if the conversation is kept going, and more patients are aware that they, that really, primary care are there to support them, then they'll be asking and knocking on the door too. So yeah.
Thanks, Heather. I think it's a question that everyone's asking, really, isn't it, in their
Mm.
systems, is how do we how do we keep something like cancer care reviews going, or is there another way that support is going to be provided for this group of patients? So I think it is that, it's probably our number one challenge,
Yeah.
I would say, in terms of personalised care and primary care. Catherine, I can see you've got your hands up.
Hi, thank you. Hi, Heather. Thanks very much for
Hi.
your presentation. My name's Kath. I'm one of the cancer project managers within the cancer team over at Lincolnshire in their ICB, and I support around with all of the work around early diagnosis and screening, but also cancer care reviews is a portfolio that I've had for quite a long time. And you've already touched on the query that I had about the QOF indicators being made redundant. I know we've tried over in Lincolnshire, to use the QOF indicators as a way of almost targeting certain PCNs or practices, whilst we can't obviously, just in terms of those that are engaging with that process and ticking off that they're actually conducting them irrespective of the quality of them. So it may be a little trickier going forward to be able to identify those practices now without those QOF indicators. Your package looks really good, and we have something similar over in Lancashire, but I've got a couple of things really. The first is that we've developed over here a cancer care review postcard. So it is literally a postcard size that we put into the hospitals to give the care coordinators in hospital, to give those people, to give patients those, so they know what to expect from primary care when they are being supported by primary care, to try and bridge that gap so people understand what a cancer care review is fairly early on, perhaps even before primary care have made contact with them. If that's something you're interested in having a conversation about or looking at what we've developed, I'm happy to do that. We've developed that with our Lincolnshire co-production group, so it's something that they've had an input into. But I'm also keen to understand with your package, I know you've got it on that website, but is it just a case of kind of lifting and shifting the package and kind of sending it out to PCNs to give them those resources for them to educate themselves, as well as having the opportunity to play back and watch the webinar? Because over here, Lincolnshire's such a huge county, it's so difficult to try and spread myself, because there is really just me across the county, and it's trying to educate people in the best way, in the most effective way, with all of that really good resources that you've talked about. And I just wonder if you know what else they might do over in your area to kind of get that message out that we may be missing a trick with.
Yeah, no, I think it's probably been the most challenging part of the project, is actually getting the word out. There is in Manchester, again, we've got several trusts, they all do things slightly differently, and it's really hard to be able to kind of you can't individually contact every single practice. There is kind of a central email where they've sent out kind of a cancer newsletter, so it's been part of that. You don't know how many people it's actually reaching, and people are actually reading and engaging with it, and that's the problem. You can just try different routes. So we've used that. We've used the Greater Manchester GP Excellence as well. So they've been quite good, because they're quite into quality improvement stuff. So they've been quite good at spreading the word. I have attended a few kind of locality teaching, but there's few areas that actually now have dedicated CPD time. So I've just done 2 of those across Manchester. But generally, it has been word of mouth, and then through the primary care early diagnosis team leads as well. So they've helped to kind of spread the word within PCNs, and they often kind of communicate with their local practices, and sometimes that's helped. So we've just tried multiple different routes, and I doubt everyone's been reached, but that's been probably one of the major challenges, really.
Okay, thank you. No, that's really helpful. We'll keep on keeping on.
Yeah.
Thanks both. There is something in actually, Catherine, about sharing the postcards. Would you be happy to share that with the group?
Yes, do you know what? I'll see if I can find it whilst we're on the meeting here, and if you want, I can try and pop it in the chat. But if not, I'll put my email address in, and then if anybody wants to contact me afterwards, I can email it out or send it to you, Sandra. I don't mind.
Yeah,
whichever way.
send it to me. I can send it out with the slides, or probably most efficient way of doing it. If that's okay.
No problem.
Perfect. So just conscious of the time. Heather, there's a question from Rebecca in the chat. I wonder if you can answer it in the chat as opposed to verbally, if,
Yeah,
if
no
that's
problem.
okay. And I think there's an ask if you can share your email address as well. So if you don't mind popping that into the chat. And before we move on to the next speaker, I'm just going to kind of mention the kind of QOF change, and obviously everyone's sort of grappling with this and thinking about what impact it's going to have on their work in terms of work with primary care. So I'm kind of proposing, and it'd be good to get people's feedback, is whether we either have an additional one of these meetings and we spend some time to collectively talk about solutions or possible solutions to the challenge, or for our next meeting in sort of May, June time, that we kind of devote that to some thinking time together in terms of sort of collective working and sort of sharing ideas that you begin to think about within your systems to sort of mitigate the QOF change. So interested to know what people's thoughts around that. So you maybe can just pop that into the chat. So thank you, Heather, for your presentation, and I think it started an interesting conversation. And I think as always, thinking about how we embed this and sustain this, which is always a challenge. But sounds like some really, really good work that you shared, and really appreciate your time in sharing it today. So I'm going to move on to our next speaker, get our slides back up, hopefully. So Tracy Gallagher, do you want to introduce yourself, Tracy?
Yeah, hello everyone. My name's Tracy Gallagher, and I work down in Dorset as a cancer nurse, I suppose AMP in cancer care, in primary care. I've been in this role now, it'll be 3 years in August. The role's fully funded by the PCN. Just to tell you a little bit about myself, prior to this role, I was a lung cancer nurse specialist, been in oncology for about 9 years, and used to see lung cancer patients. I've also been lead cancer nurse, so I'm quite fortunate that I know the teams, local teams, but I've also worked in the community as a community matron and respiratory nurse, so I've had sort of quite a varied background.
Tracy, do you want me to move the slides on for you?
Sorry.
Yeah, sure.
Are you in charge of them?
You can take control if you like. Do you want to see if you can move them on?
Yeah, let me just see.
It wasn't working for the previous speaker.
Yeah,
they're moving. Yeah, all good.
Okay. So Shaw Medical consists of I cover 5 GP surgeries. It's 1 PCN, and we've got approximately 58,000 patients across our patch. Within Dorset, we have 18 primary care networks, and Shaw have sort of mid range in terms of higher cancer rates. On average, we're seeing between 25 and 35 new cancer diagnoses a month. That includes patients that are referred in on fast track, and also emergency admissions. I think Heather's touched upon the pressures of cancer care reviews in primary care, and how they can be quite varied in terms of either planned or more opportunistic. There's also that expectation sometimes of patients, particularly at diagnosis, for them being supported and managed within the secondary care. And again, we've touched upon it slightly, but we know, because we're working in cancer, but the increase of demand of patients being diagnosed with a cancer diagnosis is increasing. And patients are presenting with usually at least one other long-term condition. And we know that patients with cancer diagnosis are far more likely to be admitted as an emergency admission once they've had their diagnosis. We also know that patients are living a lot longer on cancer treatments, and having worked in oncology, I've seen that particularly in terms of patients with lung cancer, where a prognosis may have been around 12 months on treatment, and we're looking now at, beyond 5 years. So I suppose quality of life and side effects of treatment that come with that is just like who's managing that. again, just looking around the expectations in terms of primary care and other things that my role tends to cover. So I'll move on to my role a bit more detail in a moment, but the pressures again on primary care to look at earlier detection, and a lot of money going into prevention, early detection, but not necessarily funding once patients have been diagnosed and actually managing their long-term side effects, particularly once they finish the treatment. So as I said, my role actually, one of the GPs was looking at a potential pilot with Wessex Cancer Alliance, and I think they put in a bid to sort of go with the pilot, but it didn't happen. But they were still keen to employ somebody full-time to look after their cancer patients. And that just touches upon some of the things that I do, and I'll talk a bit more detail about that in a minute. And I know, depending on where you are in the country, people have different opinions in terms of who manages and supports their cancer patients. But just to say, obviously, it's not just me; it is a whole team approach. So we do all sort of share the work, because it is a full-time job that gets very busy. So as it stands at the moment, so our patients obviously fast-tracked in, or some are being diagnosed as emergency admissions. So I will be alerted by our workflow teams about new patients that are being diagnosed with their cancer. So automatically that will set me off to triage the patient in terms of looking at what the cancer type, potentially what the treatments are, their stage, looking at the whole sort of medical history, and a real holistic approach in terms of assessment. And all that information isn't always readily available, particularly with the staging and treatment plan. But the patient is contacted, and I'll contact the patient directly, either by telephone, or if we've got information sort of where we can email them or contact them, a letter will go out, which we use a template with basically my contact details, which gives them direct number, a mobile number, and an email. And then the patient is then followed up. Obviously, it can depend on what their treatment plan is in terms of how much input they may have. But again, looking at our data, so it's not particularly clear there, but this is just alone for our PCN and where cancer, our referrals have gone in. So 6.3% of our population have a cancer diagnosis, which is, you know, towards the top. So only higher than that is depression, hypertension. So again, if we're looking at roles, and particularly within PCNs, and we're looking at other long-term conditions, and we can say that cancer has become a long-term condition, that we look at respiratory diabetes, and I know our practice nurses are trained up, and I do a lot of education within our teams to support people with cancer care reviews. But it's something that's not really cancer itself, although numbers are increasing and people are living longer and the treatments are more complex. There hasn't really been any planning for support in primary care, and more importantly, funding. And this is something my role is really trying to push, that we do have support, and however that looks. So whether you've got community teams or whether you've got people like myself within the PCN. So that the flyer just sort of goes through some of the things that I deal and manage, and every single day is different. I will see patients within the surgery. I will do a same day appointment, so I will go and see patients at home, particularly the more complex, and that will be shared care with our amazing district nurses and primary care teams. I can prescribe. I manage a lot of long-term effects, and particularly with the younger patients that have had curative treatment, that have got ongoing issues. I'm involved with their care as well. Signposting on lots of psychological support and family support. I'm also involved with we are fortunate, we do have a palliative care nurse within our Shaw Medical, which is also, we work closely with our local hospices. So I'll just pop this up. This is from Macmillan, but we all know as well, sometimes from that point of going to tests, and with the pressures on at the moment with fast tracks, that there can be a huge gap between patients going for their testing and receiving a cancer diagnosis. And more recently, I found that particularly if patients are referred on to a tertiary site, that there can be delays in diagnosis, and that can be really difficult for patients and their families. So I work as an advocate for that, of pushing forward sort of appointments and giving patients that support. And the feedback has been that having one person that they can contact for continuity has been really important. And we know that not everybody will go on to have treatment. So again, having the information and contacting that patient at an earlier time, again, has had a really positive impact. So we have looked at some of our data, and this is from last year, but when we were looking through, because see, we do the initial, I believe the cancer care reviews are ongoing, and again, fortunate in my role that I can keep that those reviews going. 50% of our patients had a palliative diagnosis within the 3-month and 12-month reviews. And of course, we know, that palliative doesn't necessarily mean they're not for treatment, and it can vary in terms of their pathways. But I thought that was quite important. 40% were complex psychosocial needs, and again, getting that support in earlier. We've got really good psychological support teams for our hospices, through a lot of our charities, where we can get patients and their families supported. Interestingly, complex palliative patients tended to be in the 60 to 69 year age group. Was quite interesting, considering we've got our population sort of tend to be elderly. And the most sort of complex, which was probably no surprise, was around the bowel, esophageal, lung, pancreatic and brain. So we touched upon the GP cancer care reviews and who was doing that previously, and it would vary. And as you say, with the tick box exercise, sometimes I think that would happen more, certainly differently to what I tend to do. Whereas now I do get a lot more time. So it can vary again, depending on the type of cancer and the patient and what support they may need initially. But everybody is offered a face-to-face appointment. For some patients, for them just to know that you're available is all they need, and they'll contact you if ever, really, but they will be followed up. So working with Essex Cancer Alliance, we've just done some work around sort of costing of the cancer care reviews and the amount of work that's sort of been done, and that they've looked at sort of, I suppose, funding, but costing around about, and they found that overall there's a cost saving there, £13,000, which obviously is could have an impact in terms of being spent on other things, but also, I suppose, looking at gold standard and quality of care for the patients. Our GPs do still carry out cancer care reviews, and they will carry out and see their patients as well, and they are informed of the diagnosis, particularly if it's a complex pathway or patients are palliative. So it's just some feedback there from we do have a counsellor within our PCN, and these slides will be shared. So I thought I'd just show, within sort of the first couple of months of joining the surgery, I contacted a 62-year-old lady, and it was just a 12-month review to invite her into the surgery, and she had metastatic melanoma. And a recent scan was pretty much around the 12-month review. So unfortunately, it showed she'd had progression of disease, and she decided that she didn't want any further treatment. So I saw her face-to-face at surgery with her daughter. And at that appointment, we were able to refer her onto Macmillan Citizens Advice Team. We've got a really good local financial support team funded by Macmillan, because there was concern about some finances and not being able to work. When I saw her and examined her, she had an enlarging node within the right groin, which was due to a melanoma, but it was really affecting her mobility. So the following day, I was able to email oncology consultant team, who, as I say, I previously worked with, and they actually saw the patient. Well, I called her the next day and got her into for a planning scan. So within a few days, everything got moving and the patient was seen. And during that time as well, we did touch upon advanced care planning. Although the patient wasn't imminently dying, we got the conversations started. There were some issues around sort of discussing the diagnosis with a 6-year-old grandchild, and that was really important to them, but also remaining active and pain-free. So seeing the patient at that point and getting things in place in terms of treatment, and actually this lady did go on to live for another, I think it was about 8 months, but we already knew her at the surgery, and we were able to sort of continually assess and get the right teams involved, so she was able to remain at home for end-of-life care. When we touch upon mortality as well, and my job really isn't, although I do follow patients through from point of diagnosis, actually a lot through to end of life care. I work really closely with the district nursing team and our specialist palliative care teams, and since I've started in my role, we've got palliative care meetings set up for each surgery each month. And I think touched upon, we are looking at 60% of our palliative patients have got a cancer diagnosis. But we also know that the numbers, actually, it has plateaued off. So again, that would back up and support the fact that a lot of our patients are having treatment, which means they're living longer, but not necessarily with a great quality of life. But as we know, then when we support them, we can ensure we're getting those advanced care plans in place and discussions, so we can look at avoiding unnecessary admissions. So patients at the moment that we feel not fit for systemic treatment, we have got really quite a nice pathway going where the district nurse teams will be informed of the patient, and for some of our patients, having some input from the district nursing teams at that point will be helpful. So we do see a lot of frail elderly patients, and a part of the assessment when I do the cancer care reviews is to look at that social sort of support and what else is going on, and particularly if they're frail, we'll refer into our frailty team. Our palliative care nurse also covers frailty. We'll also see the patients at home, and we look at advanced care planning in terms of just in case medications, DNARs, which we're all trained up to do, and support for the family. We're also fortunate we've got our own palliative care occupational therapists, and we have close links in with social care. So it's just looking at the whole holistic approach and documenting that. So every patient's got a really good advanced care plan, particularly for our teams out of hours. Excuse me. We also just had a little look at some of our data over sort of say a 3-month period, but we were looking more closely around, and we do record our preferred place of death within our care plans. And for some patients, obviously, it's difficult to have that conversation and things can move quite quickly. But we did find that 19 of our patients, well, actually 17 of 19 patients actually preferred place of death had been recorded, and we'd managed to achieve that. So again, that's been one of the real benefits from this role as well, is just that holistic approach and actually being more proactive than reactive. We've also seen a drastic reduction in pre my role in terms of admissions. I don't know if you're within your PCNs, how well you can get to know your patient, but usually it's because of they've got an issue, they'll come and see somebody rather than actually contacting you with something which might start off quite small, and is managed and dealt with. This is not to take over the work that's being done in secondary care, because patients know when they call me and if they phone my mobile that I'm not there as an emergency point of call, and if they're on treatment, they know that they ring our acute oncology hotline. But again, we looked at some of the work Wes has looked at in terms of our data, in terms of number of admissions and our average number of admissions compared to sort of more national data. So again, we saw some cost savings there, but also again, just focusing back on the fact, quality of life and keeping patients at home. Of course, for some patients, they need to be in the acute sector.
Tracy, can I just jump in for 1 second just to give you a time check? Would that be okay? Sorry to interrupt you. I just want to make sure there's a little bit of time for people to ask you questions. Do you think you could wrap up in a couple of minutes? Would that be possible? Sure. I know there's so much you want to tell us, and we've got limited time.
If I just touch upon actually this lady with metastatic breast cancer, and prior to my sort of involvement, if you like, the history is all there, but basically she'd had 14 ED admissions, as you can see, all the information there, but it was turning out to be quite costly, and in my opinion was being overly investigated for something we already knew. That she had metastatic breast cancer and she was under oncology, but she would present with abdominal pain 9 times out of 10, go through ED, and then have all various investigations. So I became involved with her in November, and we just sort of looked at between November and March with my involvement how things were looking, and basically we were able to get that right down in terms of get her into the hospice for some symptom control. I continue to manage this lady, and she continues to be at home doing well, and her admission, she has had a couple of admissions, but nowhere near as much as she was had prior to my involvement. So it's just again touched upon a complex and talking to and educating her around sort of hospice care and the fact that people don't go there to die. Some people do, but actually for symptom control, it was what she needed. So lots of different things in terms of my role. Again, we touched upon the collaboration with all our teams and how that's worked really well. And I'm the point of contact, I suppose, for secondary care. So our relations with secondary care has really, really grown, as with all the local sector. Do a lot of education, also project lead for all the innovation. So Cytosponge, yes, screened 150 patients. We're involved with lung health checks now, and currently doing a bowel screening pilot as well at the moment. So the role itself has opened up all different sort of avenues in terms of with our local alliance and integrated care boards. And we're obviously achieving all of the things we need to be doing. We used to see the signs, which we're piloting at the moment in terms of trying to get our patients in, being referred in sooner and getting our diagnosis rates, achieving our target of 75%. And finally, just a lot of work going on locally for us as well regarding our frailty screening. So part of my assessment, we will look at frailty scores, and we have a pathway for that within our local PCN. And yeah, lots and lots of positive feedback from patients, secondary care, local providers and our GPs, surgeons. So it's been a really good role, and I love the job because it's really good to be supporting these patients, but also highlighting the fact of how important it is to have funding for these roles, but just generally for cancer, so patients can be supported. That's it.
Thank you, Tracy. Thank you. And that was a whistle-stop tour, and it's so much rich data in your and information in your slides that yeah, done well to summarise it into that time. So thank you. I'm sure there'll be some questions for you. So just open up for the last couple of minutes for any questions for Tracy. And obviously we'll be sharing the slides, so people may well pick stuff up afterwards once they've had a chance to look at the slides in more detail as well. I'm just going to make a comment in while we're waiting for anybody to ask a question, was around thinking around the kind of some of the challenges we have around the GP contract and the QOF coming out. I think the roles such as yours, Tracy, provides an opportunity to kind of really embed community-based, primary care-based support for people with cancer. So I think it's a really, really good example of the sort of system change that we need in terms of these are the roles that we need out in primary care and community settings to make sure that people do get the support they need out of hospital. So I think it's a brilliant example of kind of innovation and how we address some of the challenges around the QOF funding. Is if we were able to use ours funding or other money available within systems to develop such roles, I think it would mitigate some of those challenges. I don't know what other people's thoughts are around that.
I was just going to say as well for us, because we've merged down in Bournemouth and Poole to sort of all our oncologies going to one area, but there won't be any more beds than there currently are. And the fact again that patients, the more and more patients are receiving treatment for longer, but there just seems to be no provision within the community at the moment to support those patients, for them patients to have the treatment. So at some point it will crash.
Absolutely. Everyone's gone very quiet. Okay. Any questions, comments? Are you still all there? Jane?
Yeah, I was just going to say, it's a fantastic thing you've done, and you'll just wish that we could have your role, and it just feels like with the latest news everything's gone a bit, oh God, so how are we going to get these things embedded like this? How are primary care going to use the R's money? I don't know, but I think what you've provided is a really good evidence base and something that I think it'll be helpful for us to use to have those discussions locally to see what the impacts have been of your work, which should be applicable everywhere. But that was all. I was just going to say I'm really impressed with this project and this work. Thank you for sharing it.
Thank you.
Thanks, Dan. I think the kind of, for me, the kind of key there is some of the sort of modelling around costings that you shared. So I think in terms of trying to build the case for these kind of roles, it's that. I think it's the patient experience, it's the keeping people out of hospital, it's that side, but also it's the financial benefits of being able to achieve some of those sort of tangible things like avoiding admissions, reducing perhaps GP appointments, etc., etc. So I think being able to kind of articulate that is really important. So I think there's some really good data in your slide pack to support with that. We've got Amanda, and that's probably going to be the last question.
Yeah, and it was just really to echoing what you're saying there, Sandra, and I hope, Tracy, that you're using this evidence as in the call to evidence as part of the cancer plan, because I think it's examples like this are really going to make a difference. So if you're not already doing it, but please do shout loud and proud about this work, because it is really, really inspirational and hopefully will be a model of the future.
Yeah,
thank you, Amanda. I think that's a really good point, actually, is articulating that in every way possible in terms of trying to influence policy. So it's a really good pointer, I think. Thank you. So we're at the time. Thank you, Tracy, for your presentation, and thanks for your kind of engagement and questions and support today. We'll get the slides out. I've got the postcard now, so I'll get that out with the slides to you, or probably later, or possibly tomorrow. And then once we've got the recording, we'll share that as well. And we'll have a think about the next meeting in terms of how we might use that time to talk about some of the sort of financial issues in the system, and particularly around the GP contract and the cancer coming out of the quality outcome framework. So I think it'd be good to collectively think about that. So thanks everyone, and we'll see you again in May, June time. Thanks a lot.
Thank you. Bye.
Thank you.
Thanks to both my speakers today for your support and your great presentations.